let me start by saying you all have wonderful backgrounds, and you could have done a lot of things with your time and your energy. You all have written books, and again, all the things you could have written on, you wrote specific books for specific reasons. What is the reason that you are focusing on the information you are focusing on? I mean, there's so many things to do with your time. There's ways to make money. To write a book takes a lot of time. Why are you writing on the subjects that you're writing on? You must feel that there's something important that the public is not aware of. So what is the reason that you're devoting your lives to the subjects that you are currently speaking and writing about?
Alan?
I am just amazed at how misled people can be about medical treatments. And I think that's, I came across this when I started doing drug policy research right out of university, that there's a huge amount of information that people are acting on, but it's only part of the story. And part of the story being that they're only getting often the vision that has been presented by the pharmaceutical industry. And I focus on the pharmaceutical industry because that's what I do. But you know, when you think about medical care in this country, more than 60% of physician visits will end in a prescription drug, either a new drug, a refill of an existing drug, or a free sample. And when people go into that situation, they're often extremely misled about what the benefits and what the harms of those treatments are. And for me, it was really very important to expose the fact that the science is so far behind the marketing. In this country, you've got direct-to-consumer advertising of pharmaceuticals without people really understanding the very basics of things such as their cholesterol or their bone density or their high blood pressure. And so I wanted to expose that real gap. That was why I got sort of interested in this and really kind of became a journalist and an activist on this topic.
Yeah, my answer is very similar. Is this working? Is this working? I went into psychiatry, well over 20 years ago now, and I was immediately struck by the complete difference between what you were told in the textbooks and what you saw in real life. So the textbooks told you that there were these drugs that were really effective and cured this treatment and cured this condition or this condition or this condition. And what I saw in the hospitals were people who were obviously drugged, shuffling around, quite rigid, zombified, as is often referred, as it's often called, and so and similarly with depression, it was being presented as if these antidepressants were wonderful miracle treatments and people got better. And I just saw people coming in. Sometimes they got better, sometimes they didn't get better. It seemed to me to have no relationship to what medication they were taking, and yet so many people I was working with were convinced that the medications were really effective. So I started looking into the literature. I realized that this whole idea that the drugs that we give to people are treating diseases is completely spurious. It's really not backed up by any evidence. And I feel that people who take these drugs or who are offered these drugs or who are struggling with problems and looking for their options, looking into their options, really need to have this information.
Thank you, Joanna. Education is what has to happen to bring people out, to wake them up as to what they've been sold. If you got it in America, you were probably sold it, and we've been sold drugs. Sold it on TVs, the doctors were sold, that's their educational systems, so that's what they do, that's what they were taught, and so that's what they do. You can't really understand the current situation outside of understanding that medicine is a religion. I mean, think about it. If you've ever mentioned to one of your friends to take some curcumin or boswellia instead of an NSAID drug, and they go like, what? a plant on Earth, it's just like a total disconnect. And you can't understand the current scenario outside of this religious fervor, this belief system that has been taught, that's been inculcated into the masses. We brainwashed the masses and into this belief system that drugs are the answer. And somebody's got to push back against that and educate people as to the truth that drugs are not the answer. And so that's what I think each of us are here about, is educating you about the truth, the real truth about health.
Okay, so I've been waiting for you guys to come for a long time. We've been planning this conference. I went through your books. I have a lot of questions that I'm very passionately interested in hearing, so I'm going to ask you a lot, and you can just give me, maybe we'll try for 3-minute answers, and we'll try to get through a lot of these. So to get right into it, first question, I guess. What are the risks of mammograms? And let me combine that with a second question. Are we getting accurate information on cancer rates, cancer survival rates, and the effectiveness of early detection in mammograms?
So mammograms is one of those things that we've been told, every woman's told that she should do, and if you go to your doctor, then they will call you and beat you up and hound you to get these x-rays. And they don't ever say breast x-ray. It's cute little word, mammograms. Oh, how cute. A graph of the breast. Okay. So, and you'll get hounded to death if you don't do the mammogram. Mammograms are x-rays that cause mutations that cause cancer. Getski, I'm probably pronouncing that wrong, Getski, from the Nordic Cochrane Center, was asked the question. He really got into this because he was asked by the Danish government to give them the straight stuff on whether mammograms were effective and whether that's something they should offer to the ladies in Denmark. And so they studied it. The Nordic Cochrane Center is the most prestigious analytical center in the world. They didn't have a dog in the fight. They were just asked, give us the numbers. And the result was that they said that getting mammograms increases mortality, that's death, mortality by 4%. In other words, women that get mammograms die 4% more often than women that don't. Mammograms are probably the #1 cause of breast cancer in the United States. I don't know how we're doing in the UK, if it's still pushed that much, but certainly in the US, it's a primary cause of breast cancer. It's a serious amount of radiation, about 150 times the amount of a chest x-ray, but then if you think a chest x-ray is spread out over a large amount, and we're concentrating these x-rays into the breast, so it's actually per square centimeter, it's about a 500-fold increase of what you would get in a chest x-ray. Just a massive dose of radiation to the breast, so that the statistics are really hard to sort out because they're obscured. But a single mammogram increases your breast cancer risk somewhere between 1 and 5%, but a significant amount. There's also the direct chance of causing the spread of breast cancer either by the rupture of a small tumor. I've even had patients that had metastatic breast cancer, in other words, breast cancer in the liver, the lungs, the bones, that didn't have primary breast cancer, that didn't have a cancer in the breast. Now, how do you do that? They were all faithful mammogram goers. So every woman, say that's 60 years old, has some ductal cancer cells in their breast. But they're kind of happy there. They're being contained. They're not going anywhere or doing anything bad. You get the mammogram, you smash the breast, and you pop one of those ductal carcinoma cells out, it gets into the lymphatics and travels, and then you've got metastatic breast cancers. So the radiation, the smashing. We know that women under 50, the more dense the breast, the less sensitive they are to mammograms. So for instance, mammograms are only, for women under 50, only 52% sensitive. In other words, if you have breast cancer, they only detect it 52% of the time. In other words, half of the women that have breast cancer, it's not even going to find. That is not a screening test. To reach the threshold of screening, you need to be about 80%. We're talking about 50% here. And so that's not a screening test. So why are we doing it? Especially in light of the fact that it increases cancer rate and increases death rates. So to prevent one breast cancer death, you would have to screen 2,000 women for 10 years to prevent one breast cancer death. In the meantime, you would probably cause hundreds of breast cancers, and certainly a number of those would die. So mammograms, a primary cause of, and the data, talking about the analytics, there was a 2-county trial and the Twin Cities trials. That data was falsified, as Getsky proved, that the data, figures don't lie, but liars do a lot of figuring. So people that died during the study weren't counted because they didn't finish the study, okay? And people that did well were double counted. And so it was just a statistical lie that they said that it was a 31% reduction in death rate if you got mammograms. That's just an absolute lie. The Canadians figured that out first. There was a study came out in 1992 where they said that women under 50 were not benefiting at all from mammograms, and if you were under 35, that it was a dramatic cause of breast cancer. So this data has been around since 1992. Getsky published his report in JAMA, I believe, in January of 2000. So we know that mammograms cause breast cancer. We know that mammograms do not save women's breast and lives. So it's a statistical lie, deception, untruth. Don't do it. Sorry, that was a little long-winded. But.
Do you want to also just follow up while we're on it on, are we getting accurate information on cancer rates, cancer survival rates, and the you covered effectiveness of early detection in are we getting accurate information on cancer rates, cancer survival rates, and the effectiveness of early detection?
Well, mammograms are not early detection. That's very clear. So a 1/2 centimeter tumor, which is around 300 million cells, about the size that it needs to be detected on a mammogram, that's too late. It's already spread into the lymphatics. It's already spread, so that's too late. Mammograms are not early detection, which is one of the many reasons that they don't save lives, not to mention that they cause breast cancer themselves. As I mentioned, in the Twin Cities trial and the 2 counties trial, the statistics were simply changed and artificially manipulated to create the numbers that they wanted. Today, we're still not getting good data. 5-year survival rates means that you still have a heartbeat at the end of 5 year. And these things are very carefully plotted out by the industry so that you get a best outcome. So biopsies are the standard of care, certainly in the US, probably in the UK. Biopsies spread cancer, it spreads the tumor, spreads the cancer cells, but it's going to take somewhere around 6, 7, 8 years before the spread of that cancer everywhere else in the body, from the lymphatics, those cells being carried off through the lymphatics and veins, grows up enough to cause problems or death of the patient. So we need 10-year studies. And so when you go to the doctor and they say, and if you find something, heaven forbid, they want to do a biopsy, here's what you need to ask. Show me the science that shows that biopsies do not cause the spread of cancer. They go, oh, there's no study showing that. No, you're claiming the high ground. You're claiming science. Show me the study that shows that it does not spread cancer. Mammograms, biopsies, it's the standard of care, but it's deadly.
And also, are we getting, not just mammograms, but are we getting accurate information on cancer rates and cancer survival rates?
We are not. I tried to cover that. I don't do that really well, but we are not getting accurate data.
Okay. What are the results from long-term exposure to antipsychotics for people who continue on the drugs as well as those who go off the drugs?
So antipsychotics are drugs that were first used for people who are diagnosed with schizophrenia and psychosis and are now much more widely used. And they do have some really serious effects if you take them for a long period of time. They cause a neurological condition called tardive dyskinesia. There's evidence that they shrink the brain volume, brain size, and they cause weight gain, diabetes, heart disease, sudden cardiac death. They're very unpleasant to take. They cause sexual dysfunction in most people who take them. So there are lots of serious consequences from taking them for a long time. If you stop them, and if you stop them suddenly, there's a withdrawal syndrome. There's sedative drugs, so when you come off them, they might make you a bit agitated or stop you sleeping. But there's also evidence that in some people, they might actually, people who already have had a diagnosis of psychosis or schizophrenia, they might increase the risk of getting another episode. And there is also evidence from some case studies that people who have never had an episode of psychosis might get an episode of psychosis if they're on these drugs or similar drugs and come off them suddenly. That evidence comes from drugs that are similar to antipsychotics that are used as anti-sickness drugs. And as I said, there are a few case studies that when people have stopped those drugs suddenly, they've had a psychotic episode and they have no history of having one in the past. So taking them long term has lots of consequences because they are drugs with serious adverse effects, and coming off them, especially coming off them quickly, can be risky, as it is for many drugs.
Dr. Joanna, isn't it true that the studies are usually done for months or very short periods and not years, so that the long-term results frequently aren't known or reported?
Yes, so the studies that have looked at long-term treatment, and long-term treatment is the standard treatment for people who have psychosis or schizophrenia diagnosis or a bipolar diagnosis, which is an increasing number of the population. And that treatment is based on these studies that have compared people who are already on medication and randomized to people who've been taken off. And they've randomized the two groups. So one group are randomized to carry on the medication, the other group are randomized to be taken off and put on a placebo. And then, as you say, the follow-up is usually quite short, and what you find, surprisingly enough, is that, or unsurprisingly enough, is that the people who are taken off the medication have higher rates of problems than the people who continue on the medication. But there's some evidence, and one particular trial that's been done in the Netherlands that followed people up for 7 years, and that found that actually in the long term, people who'd come off the drug, and in this case they'd done it gradually, or some of them hadn't even come off, but they'd reduced gradually. And this study found that those people were actually doing better than people who'd stayed on the medication long term.
Can I just work? Can I just make a corollary to that? When you think about antipsychotics, though, and these are probably among the most controversial drugs that we're using today, certainly the most powerful. Right now, in America, they're using antipsychotics largely in older people in long-term care facilities. These drugs are used as sedatives to calm down people who are agitated, maybe because they're super cold, their soup is cold, or they're otherwise not being well treated in a long-term care facility. You've got probably 20 to 30% of elderly people in long-term care on antipsychotics. And you look at this and you say, really? What is going on there? These drugs are contraindicated in people with dementia, which is to say that if you're an elderly person and you have some level of dementia, the drug is likely to increase your risk of death as opposed to getting something else. This is really an amazing fact that we allow this to go on, that antipsychotics are used to basically turn our older people into zombies. It's not just the elderly, though. The drugs are used in children, in people with very mild forms of depression, what is defined as a treatment-resistant depression, if you're, which is a definition by the pharmaceutical industry, in my opinion. You are depressed, you get an antidepressant drug, it doesn't seem to work, and then they move you up to an antipsychotic. And that is really just the beginning of some serious problems, as Joanna's described.
Shall I just describe the drug company's role in that? So in the 1990s, various pharmaceutical companies realized that there was this huge market for antidepressant drugs, and they had these new expensive antipsychotics that were going to go off patent, and they decided that they wanted to capture the market for antidepressants. So they started to present their drugs as treatments for complex mood disorder, bipolar disorder in a form that was massively expanded, and for treatment-resistant depression.
What does the evidence say about the risk versus benefit for men to have a PSA test?
So I'll answer that very quickly. A PSA test is just a very simple blood test that measures an antigen in your blood. It's offered to men who are 45 or 50 years old. Your doctor will say, you're at that age where you might have a higher risk of prostate cancer, and I'm going to give you this test. The test, however, what you probably won't learn is that could be the beginning of a medical nightmare for you. The PSA test is used, as one author described it, as lure to draw men into this bait to get their prostate removed. The stark reality of prostate cancer is that most men will die with it, but not because of it. Which is to say, this latent cancer can live in your body for many years. You'll die of something else. I'm 54 years old. There's a good chance that I have a 50% chance, if they inspected my PSA levels, that I would have some level of prostate cancer. Would I do anything? I wouldn't, because I think the main problem of testing men for prostate cancer with this test is that the test is not very specific and it's not very accurate. And so you get a huge number of men who are treated for prostate cancer for something that is likely to never go on to hurt them. And those men will get surgery, they'll get chemotherapy, and some of them will go on to become incontinent and impotent. A PSA test is a very bad idea. And this is not just Alan Cassels giving you my opinion. This is the opinion of the United States Preventative Services Task Force, who has essentially given the big thumbs down to PSA testing. And any man who's offered one, you need to stop and take a very close look at the information and the evidence around the harm related to PSA testing.
If I can speak, I had a friend call me up a few months ago. PSAs are normally down around 1, I mean, pretty low, 1, 2. He called me up and said, my PSA is 15. What do I do? The doctor wants to do a biopsy. I said, well, okay. Did he examine your prostate? Yeah, he examined my prostate. Before he did the blood test? Yes. I went, then it's meaningless. What do you mean it's meaningless? I said, it's meaningless. When he squeezed your prostate and examined your prostate, he put PSA into your bloodstream. I said, it has no meaning because it's irrelevant because of the doctor's exam before the blood test. So I had him go back. He had a PSA, I think 1.2, 1.3 or something, without the finger wave test. And so it all has to be very carefully, properly done.
Yeah, and if you, the night before, if you bounced on your trampoline or
have
rode
sex.
your bicycle or had sex, there's a good chance you're going to have a PSA test. Now, are men told that when they're, the results come back and it's high? I don't think so.
What is the link between birth control pills and breast cancer?
Anytime you stimulate the breast tissue with estrogens, be they xenoestrogens, equine estrogens, estrogens that might come through dairy products from cows where they give them bovine growth hormone, or any way you're stimulating the breast tissue abnormally, you're going to increase the breast cancer rate. We knew that from the Premarin studies. We know that from birth control pills. Any artificial estrogen increases the risk of breast cancer, and that we've known that for decades and decades. So,
please explain, Joanna, what you meant in your book when you said the expansion of the concept of bipolar disorder has been one of the key strategies employed to expand antipsychotic use into the wider population.
So, bipolar disorder is the new name for something that used to be referred to as manic depression, and it was a very rare and very obviously recognizable condition in which people became very manic and aroused and overactive, or become manic, aroused and overactive for at least weeks and sometimes months at a time. And they usually do crazy things, don't sleep, do all sorts of damage and end up in hospital. So that wasn't a condition that was really of very much value for a pharmaceutical company. But in the 1990s, people started to talk about the use of drugs for this condition as mood stabilizers. And the concept of a mood stabilizer and the sort of concurrent concept of unstable moods suddenly opened up a much wider group of people to the sorts of drugs that were then being prescribed for manic depression. And the manufacturers of the atypical antipsychotics realized this and set out to position their drugs as mood stabilizers so that they could get into the mood stabilizer market. And then they started to expand the notion of bipolar disorder itself. So in what they referred to some research which had been done by psychiatrists suggesting that there were other forms of bipolar disorder other than the very sort of characteristic classical form, and these were referred to as bipolar 2 or bipolar spectrum disorder. And the drug companies took these ideas and really came up with this new idea that bipolar disorder consisted of being up and down with your mood, having mood fluctuations, being very confident one minute and very anxious the next minute, being productive one day and unproductive the next day. And this sort of concept, of course, could be applied to almost anyone. And they knew that, if they could come up with a concept that was really flexible, then they could get into that market for antidepressants and get to the much, much larger number of people that go to their doctors with more ordinary everyday problems than the classical manic depression.
Can I just add to that? And you might be wondering, well, why would my doctor buy into this kind of reshaping of a disease by the pharmaceutical industry, which is taking maybe the normal ups and downs of mood, reshaping it so that it's a disease that requires an antipsychotic? And I can tell you, of all of the specialties I've looked in this book, Selling Sickness, psychiatry is probably the one in which the ties between the doctors and the drug companies are the strongest. And you've got major conferences sponsored by the pharmaceutical industry that makes antidepressants, anti-anxiety drugs, antipsychotics, and the wining and dining and care and feeding of our physicians by the pharmaceutical industry when it comes to mental health, particularly psychiatry, is probably one of the biggest scandals in medicine. And the APA has been described as one of the marketing arms of the pharmaceutical industry. I went to a psychiatric, an APA conference once, and I can tell you it was like a circus. These big conference halls where the tables with all the vendors and all their drugs and all of the displays and the free gifts and just the schmoozing between the salespeople and the doctors was something that I found so amazing and amazingly offensive at the same time. So when your doctor gets ideas in their mind that what you have is something that can be treated by a pharmaceutical, by an antipsychotic or an antidepressant, it's quite likely that that message has been planted very firmly by these kinds of conferences and the specialists that they support and the research that they do.
And the APA is the American Psychiatric Association.
Just to add to that, I think the influence of the pharmaceutical industry is slightly less in the United Kingdom, but it is also tapping into vulnerability and insecurity among people. So people are increasingly being told that if you have problems in life, go and see your doctor. There is an answer. I think you were referring to this earlier. It may be, you may end up with a label of depression, you may end up with a label of bipolar disorder, depending on the flavour of the month or what drug rep has visited recently. But there is that vulnerability and out there that the pharmaceutical industry is playing on.
Alan, what do you mean when you say it's a scandal currently that people aren't systematically doing an assessment of what's known already before embarking on new research?
So the issue is, if you've got something to test to see if it works in people, the first question you have to ask is, has it been tested before? Is there any other research? Is it even worth investing money in testing to see what this has done? And if there are 5 or 10 other trials that have been done, probably the best use of your time is to systematically analyze those trials and produce sort of what are the overall meta-analysis of that work. So this is what the Cochrane collaboration has done, and I'm just going to hold this up. The Cochrane collaboration was formed in the early 90s, in 1993. A group of scientists got together and said, so much of our medical research money is being wasted because people are not doing systematic reviews of existing literature, right? A new study comes out, you should not get excited about a new study because a new study might be the 14th one that has been done. How does that study compare to the other 14 trials that have been done? And this is what the Cochrane collaboration does, is that it invests money in doing this kind of dogged, systematic review of research. And that's why I would consider some of its work to be, the highest quality that we have. You can't, you have to remember that research does not exist in isolation. If you're studying a drug's effect on a group of people in Canada or the United States, there's a good chance that it's also been studied in South Africa, in Norway, in Sweden, in Mexico. What you need to do is look, how have those overall studies together and what have they produced? And I would say that some of the best work around systematic reviews has been done in, say, something like mammography with Peter Gauthier and the Nordic Cochrane collaboration, where they said, instead of looking at a single study of mammography, let's look at the big picture. How do all of these studies fit together? In fact, some of the best research was done in Canada, of all places, and found that, again, the yields are very low and there's large rates of overdiagnosis. So systematic reviews, and in fact, I would counsel individual people to say, when a doctor's offering you a new drug or a treatment, you would say, excuse me, doctor, can you explain what the systematic review of that drug in a patient like me says? And if they can't answer that question, it might be time for a second opinion.
How can wearing a bra affect your breast cancer risk?
Bras do several things that are not healthy for the breast. First of all, they heat the breast. So let's talk about men for a second. If a testicle doesn't descend into the scrotum, which is several degrees cooler than inside the abdomen, it's highly likely to become cancerous, like over 80% probability that it will become cancerous because it's an organ that's made to be cool, that's being heated. So bras are thermal insulation kits. They keep heat in the breasts. The breasts are outside of the body. They're made to be cooler than the inside of the body. So when you heat them up, that's not a healthy thing for them. Secondly, because they're applying some pressure to the breast, that's decreasing blood flow. So think of putting pressure on any organ of the body, any place, you're going to decrease blood flow. Hello, that's oxygen, that's nutrients, amino acids, essential fatty acids. So you're decreasing nutritional and the life force to those tissues. That can't be healthy. And by the same token, you're decreasing lymphatic drainage. The same pressure mechanism decreases lymphatic drainage. So let me help you understand what lymph is, because most people don't understand. There is not a little artery going to every cell in the body. So we leak. So there's the arterial system, the venous system, and the lymphatic system. The arterial system, when you get to the end of that, it's very porous, actually. And so fluid leaks out of the blood system carrying oxygen, amino acids, essential fatty acids, all these nutrients with it. And then it bathes the cells in this nutritional complex. So the cells, this is flowing by it, and the cells are going, oh, I need that fatty acid. I need this mineral. I need this essential fatty acid. And then it takes it inside, and it uses it. And then there's the waste that comes from any manufacturing process. Well, again, there's not a little vein coming from that cell, so the cell just throws the garbage right outside of the door, right outside of the cell wall. And so the garbage collection system of the body is the lymphatics. So it's actually open-ended out there in the tissues. And so this swamp of unused nutrients and waste product is lymph fluid, and then it gets slowly collected into the lymph vessels. And then when we move, it gets returned back into the vascular system. It has no muscles in the wall of lymph vessels, but it does have valves, so that as you move, it kind of gets squeezed one way. So that's waste. Lymph is waste, among other things. And so if you've ever been in a city with a garbage strike, it only lasts about 3 days because it becomes intolerable. And so you're backing up waste into the local tissues, and that is not a healthy thing, to back up waste and toxins around any tissue. So those are some of the things that bras do that are unhealthy for the breast.
Do pharmaceutical companies financially influence the results of drug research, clinical trials, and drug studies to make their drugs seem more favorable and less dangerous? And how do they do this?
The easy answer is yes. How they do it, let's just say that most of the clinical trial research in the world really is financed by the pharmaceutical industry. And you might say that, what's wrong with that? They have drugs that they're developing, they need to test them in order to get them approved by the FDA, and they have to do clinical trials. Oftentimes they're doing it in trials in people who might benefit from this treatment, so they're providing a sort of sense of whether the drug works or not. The problem is, in my opinion, of course this is my opinion, is that every step along the way, when the pharmaceutical companies are paying for the research, they're expecting results. So you see huge numbers of problems along the way, including research that either proves that the drug is harmful and that research gets buried, Joanna can probably talk about how that happened with antidepressants, where when they've got the control over the research, they can determine how it gets used. Now, there are scientists in the world right now, I don't know if you've heard of the all trials concept, where they are demanding, and this has been a recent thing, and I think quite a good movement, they're demanding that drug companies have to register their trials before they do them, before they start enrolling patients. And they have to say, this is what we're going to study, and this is what we're going to look for, and these are the results that would determine a level of success of this drug. And if they don't register the trial beforehand, then a lot of major medical journals will not publish the results. That's a good thing, because it hasn't always been that way. They've done trials in the past, and in fact, And the trials that prove negative, they've buried them. So this idea of publication control is really something that I think has been quite a scandal. The world is coming awake to it. Joanna, you could probably give some good examples where publication bias has really influenced.
Yeah, we know that with antidepressants, for example, but I'm sure it's true for all sorts of other classes of drugs, the drug companies bury negative trials to such an extent that it really makes a difference as to whether we consider the drugs to be effective or not. So if you add in the negative unpublished trials to the positive published trials of antidepressants, suddenly the differences between the antidepressant and placebo are minute, really clinically irrelevant. The most famous antidepressant trial, which shows how the pharmaceutical companies do this, is a study called Study 329, and it was a study of paroxetine, which is Paxil in the US, isn't it, in children. And it was basically a negative study that showed that there was no difference between the Paxil and placebo, but there were some nasty adverse effects, including children getting really agitated and some having suicidal thoughts. And the study was published as showing it was effective and it was safe. For legal reasons, the company had to publish all their papers, and it was found that the outcomes that they were initially going to look at were negative, so they then changed their plan and said, okay, we'll take this outcome here. That looks as if it's a little bit positive. We'll use that and we'll pretend that was our main outcome, and we'll bury what we said was our main outcome in the small print. So the main outcome that was proposed at the beginning of the trial was there in the published paper, but you would never have known that it was actually a main outcome. It was just a tiny line in a table, and they'd elevated some test they'd done that showed a small positive effect to be their main outcome. So that's how they do it. It was clearly showed in these papers about Study 329. Incidentally, the study was rejected from the first couple of journals that they sent it to, because the journals realized something fishy was going on. It didn't look right. But they kept trying, and they got it published in a reasonably reputable journal as they wanted it to be published. That's a story about antidepressants. It's clear that it happens in all sorts of conditions.
This is routine and rampant in the industry, and that's why projects like the Cochrane collaboration are so vital. For instance, when they brought Vioxx into the U.S., they already knew that it was a disastrous drug because the studies had been done in Europe. They knew that it was going to cause X number of heart attacks and X number of strokes, but they set the price so that they could cover the legal expenses. They knew that it was going to kill people. They went ahead and put the drug on the market anyway. They just set aside X amount of dollars, and they knew what their profit margin was going to be. And this type of obfuscescence work happens all the time, where they bury data, don't include data, or ignore data in trials in other places. So it's not a healthy system.
Let me add one more example, and this is outside of psychiatry or mammography, and this is cholesterol. So the major cholesterol-lowering trials have been done by this cholesterol trialists in the UK, well, in Europe. And over the years, we've discovered that those trials are not actually made public. They selectively release information about the trial in the trials in a way that makes cholesterol-lowering drugs appear to be vastly more effective than they are. In fact, I would argue that cholesterol lowering with statins is probably the biggest waste and the biggest scandal in the pharmaceutical industry almost ever. Bigger than Vioxx, bigger than antidepressants. When I look at the audience here, probably 25 to 30% of you who have either been prescribed a cholesterol-lowering drug yourself, have certainly had your cholesterol tested, or have a loved one that has had their cholesterol tested. When you look at the overall benefits and harms related to these drugs, information that for years has been, I think, hidden, or shall I say, distorted for physicians, you realize that the benefits of cholesterol lowering with statins is very minute. For healthy people who haven't otherwise had a heart attack or have heart disease, the benefits are non-existent. People who have had a heart attack might have a 1 to 3% benefit, but still, the side effects related to the drug, including muscle weakness and cognitive difficulties. I'm saying that because people are going to be going to their doctors and saying, I think my cholesterol lowering drug is causing me to have, I can't get out of a chair anymore. I can't walk up the stairs. And the doctor will dismiss it. That's because the information on the adverse effects of cholesterol lowering drugs has been hidden from the doctors for years. It really is a very scandalous state of affairs.
And I think cholesterol-lowering agents, statins, are a primary cause of dementia and Alzheimer's. Every hormone in the body, the basis of it is cholesterol. So if you don't have enough, your liver will make more because it's a primary essential building block for so many things, including brain cells. The statin, I agree, the statin scandal may be the greatest of all scandals.
When I listen to a commercial about sugary breakfast cereals, I know that they're not good for me. And most people know that also. But when it comes to a drug, when we go to a doctor, most people feel pretty good that doctor went to 4 years of undergrad. He had a very high grade, so he went to med school. He's a very smart guy. He's honest. We like doctors. The doctors are giving us drugs based on the clinical trials. So everything a doctor tells us, who we trust, is completely based on the results of a clinical trial. So as long as the clinical trials are mostly accurate, then we're okay. But are you saying, so the question is, should the public assume that drug trial results are accurate, unbiased, and reliable, or should we say they're not? Because if you're saying that we shouldn't assume they're accurate, then how could we assume anything the doctor tells us, even if he has the best intentions, is accurate if he's reporting on drug trials that we're saying were not accurate?
Let me defend doctors for a second. And when we've studied this, and frankly, I have been involved in studies where we've looked at the influence of the pharmaceutical companies on physician education, okay? So we're talking about doctors that see pharmaceutical reps in their offices, have lunches brought to them, go to conferences sponsored by, oftentimes it'll be a colleague doctor who is paid by the pharmaceutical company to come and speak about the newest antidepressant or the latest antipsychotic. So you think, well, he's a good guy, he just practices down the street. Knowing that he may be getting several $1,000s for a 1-hour talk to convince his colleagues of the benefits of this treatment, the single most, I think, important factor in determining whether your doctor is getting good information about, really about disease and about treatments is the degree to which they have contact with the pharmaceutical industry. And this is, again, not just my speaking. This has been studied over years and years. In fact, I'll tell you one study that blew my mind, and this was a study called There's No Free Lunch. And they took a group of doctors, there were several hundred doctors, and some of them, so they randomized them, some of them were sent to a Caribbean island to attend a 2 or 3 day symposium or conference on this new drug. And the other doctors were, stayed in their practices in New England and so on. And then they fought, and of course, beforehand, the doctors were surveyed. Do you think that attending this conference is going to influence your prescribing of this company's drugs? Absolutely not. I can't be bought. I'm a professional. Okay, good. So let's study this. And then they followed the prescribing of those doctors who went to the Caribbean vacation versus those who didn't, and they found some very surprising things. The prescribing of this drug, which was, I think, was a kind of a marginal antibiotic, was not only 2 or 3 times, it was like 20 times higher than it was for the physicians who stayed at home. Even though it cost the country thousands of dollars to send all those doctors to this island, it paid off in sales and prescribing down the road. So, I would say that, there's a lot of problems in medicine, but when it comes to drug information, I think the single biggest problem is the conflicts of interest in the education of our doctors. Do doctors learn about nutrition? Do they learn about alternative treatments to drugs? No, because you don't have very expensive, very slick and very convincing reps going to their offices and telling them why patients should be, taking a plant-based diet, for example, if they've got diabetes and so on. So, we're skewing the education of physicians by allowing this contact and this influence by the drug companies. And, again, it's not just me speaking. This is well documented in my book and other books, and it is a clear example of something we really don't want medicine. Because at the end of the day, when you go to your doctor, you want her to make a decision based on you, your preferences, and the best evidence, the systematic reviewed evidence, not what the drug rep dropped off at their office last week.
Just to add, so pharma money helps drug company helps medical conferences to be held in nice, glamorous surroundings. Maybe not always in the Caribbean, but in a nice hotel in London or New York or wherever. And that, of course, helps doctors to feel important and valued. But I do think things are changing to some extent. The British Medical Journal has had a big campaign against pharmaceutical industry influence. And a few years ago, there was a president of the Royal College of Psychiatrists in the UK who banned any pharma funding from any pharma sponsorship from the annual conference. And the annual conference was therefore held in a very scruffy student university in completely different surroundings than usual. They've sadly haven't stuck with that and have gone back to the posh hotels, but it showed that it could be done. It was perfectly well attended, it just wasn't as glamorous as usual.
Just let me go further with that question. Just the nature of a drug trial. In other words, if all medicine today has to have a drug trial to be approved, Ben Goldacre, who's a writer, wrote a book called Bad Pharma. And in this book, which he said something to the effect that you can do lots of studies and only report on the ones that you want. Now, maybe I misinterpreted it, but the way I heard that was that you could do 20 studies and report on the 3 that came out good and not on the other 17. So again, everyone is using medicine, and everyone is using it based on that a drug trial was done that said, 1, it's effective, and 2, it's not dangerous. So are drug trials, are they allowed to influence, is whoever does the drug trial able to make it come out better than it is? Is it possible that when we go to a pharmacy and we get a drug that we think is safe, that the doctor thinks is safe, it actually was never tested correctly with that the drug trial process was not really a fair trial, and so if they really did 20 trials and 3 came out good and 17 came out bad and they buried the 17, that would be very misleading. So again, the question is, should we assume that drug clinical trials are accurate, or should we assume that they're not accurate? How should we think about this?
I think the way we should think about it is that we need to ask more questions. And Ben Goldacre, by the way, is behind this All Trials organization that I've mentioned that is really at the forefront of getting companies to register their trials. The problem, and maybe it's not a problem, but one of the situations happens that they test drugs in certain types of people. For example, a drug for osteoporosis will be tested in women who have been defined as having low bone density based on a certain definition, 2.5 standard deviations below a mean of the bone density of a 35-year-old woman, for example. So, and that woman who has this low bone density has been diagnosed with a DEXA scan and have determined that they've got osteoporosis. The drug might be indicated for that person. Well, what about other people? So when I say indicated, this is a really important word. A drug gets an indication, which means that it has been indicated, tested in that type of patient. But what if you don't have that low of bone density? Or what if you have normal bone density, but you're just worried? Will the doctor prescribe the drug? The question as a patient you have to ask is, Well, what is the drug indicated for? Is it indicated for someone who has low or very mildly normal low bone density? So this is a question that you need to ask whenever someone is coming at you with a prescription pad, is what is the drug indicated for? Because sometimes when they test the drug and it gets approved for some indication, it gets not approved for other indications, which is to say antidepressants. Some antidepressants, and you can correct me if I'm wrong, are indicated for adults who have this level of depressive symptoms or so on, but not indicated for children, which is to say you should not, the drug has not proven itself in children. But what happens when the drug gets approved, gets on the market, and then everyone starts prescribing it? Well, guess what? Doctors are not held bound by the indication. They can prescribe it to whoever they want, who they think it might help, which might be a good thing in some cases, but sometimes the doctor doesn't know that the drug is contraindicated in other populations, which means that you shouldn't be giving it to those patients. Maybe in one case it might be children or pregnant women. And so knowing the indication of a drug is a really important piece of information. And that is often obscured. That will be proven by the clinical trial, which, as we indicate, might have some problems. But at least when you ask when you're being prescribed a drug, knowing what it is actually been tested in is a very important piece of information.
And another thing that you have to realize is that, like the bone density, you'll never see a drug tested against exercise, okay? Or diet. You'll never see a chemo agent tested against placebo, because the placebo would win every time. You'll only see a chemo agent tested against another chemo agent. So it's not set up for health or for your welfare. It's set up to sell a drug. Follow the money. Bill Clinton taught us that.
And when you think of some things that have wonderful nutrition-based solutions, let's say type 2 diabetes. So you've got high blood sugars. We know that there's been solid research on plant-based diets and just altering your diet, reducing carbohydrates and so on.
Exercise.
And exercise does wonderful. People throw their drugs away. They get rid of the insulin because they went from being a diabetic to being a non-diabetic without any drugs. And so the question is, how often does that information get conveyed in a clinical encounter with a physician? And, frankly, the education around nutrition in medical school, I think, is still really lacking.
I'd like to ask you the relationship between breast cancer and 6 different things. So let me name 6 different things and tell me if there's a link between that and breast cancer. Number 1, antiperspirants. Number 2, microwaves. Number 3, pesticides, fertilizers, herbicides. Number 4, x-rays. Number 5, antibiotics. And number 6, tricolcin, which is, I guess, in like the hand soaps that people wash to make you antibacterial soaps. So those 6 things, can you tell us if there is some relation with that and breast cancer?
Run over that list briefly again,
Okay.
please, Steve.
So antiperspirants, 1, microwaves, 2, pesticides, fertilizers, herbicides, 3, x-rays, 4, antibiotics, 5, and tricolcin, which I believe is the antibacterial thing in like sanitizers for hand soap and things like that.
Got it, thank you. Antiperspirants, we're back to the lymphatic system. Many have aluminum in them, but just not perspiring. Perspiration is a way to get rid of toxins. And so we're decreasing our detoxification system, its ability to detoxify. So that doesn't sound healthy. So antiperspirants, and especially right there, women more so than men, because the lymphatics from the breast, especially the outer quadrants of the breast, go right through the armpit. So antiperspirants are not a good idea and are a link to cancer. Antibiotics, I want to really go off on antibiotics. Antibiotics are a primary cause of breast cancer and disease in general. Antibiotics are awesome if you're in a life-threatening situation and you really need antibiotics. I'm guessing 90 to 95% of antibiotic prescriptions are unnecessary. And what they do is they kill up. Bacteria are our friends. Actually, we are parasites. There's about 100 trillion of them, and there's only about 10 trillion of us, more or less. People diverge a little bit on the numbers, but we're outnumbered about 10 to 1 by our bacteria. And so we're parasites off of our bacteria and their products. So we want to have the best bacteria we can have to be parasitic on. And so antibiotics kill off the good bacteria, the beneficial bacteria, and promote the growth of fungus and bad bacteria. And those are not good things for us to be getting our nourishment from. So we know that, for instance, women that have, I think, 4 courses of antibiotics by their 18th birthday have a 3-fold increase in breast cancer. Like what? There's just actually been papers published in the last few years that show that the ducts of the breast actually have their own little biome, their own bacteria that live happily in there and are beneficial. Antibiotics kill those off, allowing bad bacteria and or fungus to flourish, and therefore the increase in breast cancer rate. And so you're killing off the healthy bacteria, and it's pretty disastrous. It's probably a significant cause of chronic fatigue, probably a significant cause of fibromyalgia, because another thing that antibiotics do is there's a little thing inside of our cells that's called the mitochondria. They're the power plants. So we have these central organs. We have a central nervous system, a cardiovascular system that pumps blood every place, a central detoxification system, the liver. We don't have a central system for that. So that energy production occurs on a cell-by-cell basis, and the little energy plants are called mitochondria. For all the world, a mitochondria looks just like a bacteria. It has its own DNA, its own little cell wall, and so it's if you would, an intracellular bacteria. Antibiotics kill off the mitochondria too. So it's like being in a city when there's a brownout. The power just goes down and nothing works properly because there's not the proper power. That power shortage is a primary cause of cancer. When the cells can't use oxygen in the normal way and use the full source of energy, it kind of has a brownout and it kicks in an alternate energy system called the Embden-Meyerhof pathway, and that's what cancer cells use to get their energy. So antibiotics are probably a primary cause of cancer, certainly a cause of breast cancer, a cause of many sorts of dysbiosis and disease in the body, allowing fungi to flourish and many other things. So microwaves are not good for us. We've known that for a long time. So let's broaden that a little bit. Electromagnetic frequency is not healthy for us. From our biome to our cells, disrupting. The cells talk to each other all the time. Our cells are in constant communication. Even the bacteria in our bowel are talking to our brain. So you eat sweets for a few days and then stop and see what happens. Those bacteria that you've been nourishing are going to send to the brain, say, send me sugar. Truthfully, pay attention. You're eating healthy, and then the healthy bacteria are going to send healthy messages to the brain. So there's constant communication everywhere in our bodies, from bacteria to us, from between our own cells. Microwave and EMF disrupts that cellular communication in so many ways. X-rays, a primary cause of cancer. We've known that since the invention of X-rays. Madame Curie died of cancer. Röntgen died of cancer. All of the people that worked with X-rays before they knew to protect themselves from X-rays died of cancer. X-rays cause cancer, and leading cause of cancer in America, probably by 2020, it's estimated that it will be medical industry. from antibiotics, from x-rays. We're passing out CT scans like candy. And those are massive doses of radiation. Radiation is cumulative. Every one you get increases your risk of cancer for life. So x-rays are not good. We've known that for a long time. The tricloc, how did you say that, Stephen?
Tricolson?
Yeah, tough word for me. My tongue doesn't wrap around that well. It was invented for surgeons because it's a bactericide. It will kill bacteria. It's gotten broad use. It has a distinct smell. I smelled it today when I flew in to JFK. I could smell it in the hand wash soap in the bathroom there. It kills healthy bacteria. It is a toxin. It's an endotoxin. It's hard on your liver, hard on your brain. So it's not a good thing. There's no good trials on it to say that it's safe. We do this GRAS thing, generally recognized as safe. If it hasn't proven to kill you readily, then it's generally recognized as safe, and they put it in things without ever proving that it's safe or acceptable. Did I miss any?
Nope.
I think I got them all. So.
Let me just, and pesticides.
Pesticides, I did miss pesticides. So
Thank you.
chemicals, needless to say, most of them are untested relative to damage to the body, toxicity of the liver, kidneys, brain. Many are neurotoxins. We're very aware of glyphosate, how toxic it is. Now with GMO foods, they're actually putting pesticides in foods, and so you're eating and we're a bug. We're a big bug. It's made to keep the bugs from eating the food, but we're a big bug. We're a dynamic biological system, and so it damages our systems too, not just the bug that's supposed to be eating the corn or soybean or whatever. So these are not healthy for us. You need to be eating non-GMO food. You need to be eating organic food. You need to clean your water because most metropolitan areas, the water is full of pesticides and chemicals. Millions of these chemicals out there now, and most of them aren't tested. And so we need to be purifying those. Activated charcoal is a great way to take most of those chemicals out, but you need to be very proactive about protecting yourself from the environment, from water. I mean, they put chlorine in the water. I read in the newspaper a few years back where the American Association of Water Treatment Specialists or whatever were meeting, and they said it from the stage that they knew that chlorine was causing cancer. They knew chlorine was causing disease. This was by the people that are putting it in our water. They just didn't know what to do about it. You see, they can't send the water there and let you get dysentery. If there's a break in the water line, it gets bacteria in there, they've got to kill that. Ozone can sterilize water, but then it comes out of the water, so it doesn't stay in the water all the way to your faucet. So I understand why they do it. That doesn't mean that it's healthy or good for us. So chemicals are basically very bad for us. Avoid them as much as possible and protect yourself from them in every way that you can, from things that you put on your skin to the air that you breathe, to the water that you drink, to the food that you eat. So every way that you can, protect yourself from chemicals.
Let me just follow up on that with a few more quick little things. You all flew here. When you fly, are you willing to go through the airport, the full body scanner, number one? When you go to the dentist, do you get x-rays, number two? And number three, are you okay to swim in a swimming pool that's been cleaned with chlorine? Those 3 points.
Well, I always opt out for the scanner. It's actually kind of they do the pat down. I kind of think of it as a lymphatic massage. So I've kind of gotten to where I'm into it. Okay, yeah, go for it. It actually helps decrease my stress level, and I'm just into it now. Yeah, go for the pat down. I was TSA pre-check today, so I didn't get the pat down. I missed it. But no, I never go through the scanners. So that's my response to the scanners. And there were two other questions there.
Yeah, so the scanners, do you get dental x-rays, and do you swim in a swimming pool that's been cleaned with chlorine, which most pools are?
Well, the x-rays, we've talked about them briefly. X-rays are probably overutilized. I'm not a dentist. I don't speak well to that. If you're going to get an x-ray, let's go at it from a different angle. You should probably eat your little basket of blueberries that morning, and take lots of antioxidants to mitigate any radiation damage. That's true for any x-ray. Before you get an x-ray in any facility, they should have a little bottle of antioxidants that you should take there to help mitigate the damage. That's so easily done, and good studies, published peer-reviewed studies, showing that you can mitigate the damage. But they wouldn't dare let you think that you could be harmed by an x-ray, so they aren't about to do that. Avoid x-rays whenever possible. Maybe 7 or 8 years ago, I had dental x-rays where they were putting a cap on, but certainly haven't had any in the last 5 or 6 years.
Okay.
Swimming pool. That's a tough one. Exercise may mitigate the damage that the chlorine might do. There's a lot of kids out there swimming, and we aren't seeing a lot of diseases, but we've got a lot of things coming at us. If I were going to swim on a regular basis, I would take a nice dose of antioxidants before I went in that pool. I'd prefer to swim in a saltwater pool, which has a lower level of chlorine. If you can certainly swim in fresh water or the ocean, that would be much preferable. So chlorine is a killer. It kills bacteria, it kills cells. Chlorine is a toxic chemical. I mean, there's no way to slice that. There's no way to do an in run on that. So if you're going to swim in a pool, try to mitigate the damage with antioxidants.
Information produced by drug companies, patient groups, and professional organizations emphasize the idea that bipolar disorder is caused by chemical imbalance in the brain. Does the research support this statement?
So this idea that depression, schizophrenia, bipolar disorder are caused by chemical imbalances has been widely promoted over the last couple of decades by the pharmaceutical industry and by patient groups and by professional groups as well. There's absolutely no evidence at all that there's a biochemical imbalance in any of these conditions, but certainly not in bipolar disorder. In bipolar disorder, there isn't even a theory. At least there's a theory in depression, even if there's no evidence to back it up, and at least there's a theory, and there have been several theories in schizophrenia and psychosis. Again, there's no evidence to back them up. But in bipolar disorder, there isn't even a theory. That hasn't stopped the message from being propagated all over the place. And of course, it's a message that helps to sell drugs because you need the drug to rectify the chemical imbalance, and it helps to keep people on the drugs for years. The idea that there's a chemical imbalance is often coupled with the idea that this is a lifelong condition and you've got to keep taking the tablets.
Can I just add to that, in that, a lot of people whose lives are not very good, whether they're living in stressful situations or poverty or abusive situations and so on, are going to have some level of mental distress. But the fact that we take that and then sort of jam that round peg into the square hole of depression is really a phenomena that continues to amaze me. That of all the life stresses and life problems that many people have, and I'm not saying that people are malingering when they go to the doctor and complain about not being very happy with their lives, that they suddenly are told that you have a chemical imbalance. This is the idea of taking a social situation and creating a medical situation out of it. And I think that the other area that we see this happen routinely and without people even thinking about it is where you've got young, mostly boys, who are rambunctious. They run around the classroom and they throw things and they don't sit still and they yell a lot. And the teacher tells the parent that your son, usually it's a boy, needs to go and possibly get checked out by a psychologist or psychiatrist. They'll go to the family doctor, and the doctor will say, yes, it looks like your son has some level of attention deficit disorder, and that results usually in an amphetamine-like stimulant, which will work, will calm the person down, calm the boy down. The question is, when you cram 25 or 30 kids in a classroom with one teacher, and you've got 2 or 3 of them who are extremely disruptive, it makes it difficult for the teacher to do their job, and therefore you need those kids to be calmed down. So the pressure, we've created a social situation instead of, maybe the teacher needs an aide, or maybe those boys just need to go out and run outside a little bit more. We've created this social situation which becomes a medical situation. And I can tell you there are some serious problems with doing so, because once you've declared someone or give someone a diagnosis of attention deficit disorder, they're going to carry that diagnosis probably for the rest of their lives, probably to not any benefit.
I'm absolutely confident that I would have been placed on these drugs as a child. I couldn't sit in my seat to save my life.
Can I just say one other thing? We did a study in British Columbia, colleagues of mine, and we looked at the rates of, if you're interested in me talking about attention deficit disorder for a second, we looked at the rates of attention deficit disorder prescribed, the drugs that were prescribed for this, and we found something very interesting. We found that the boys and girls, that were born between January and June, and we took that as a cohort, and we compared it to the boys born between July and December. And we found that the rate of attention deficit diagnosis was twice as high in the boys who were born in the latter part of the year. So you might say, what is going, we call this the birth month effect. We studied this, and it's been replicated in other studies in the world, by the way. If you were unfortunate, like I was, to be born at the end of November, my likelihood of being diagnosed with attention deficit disorder is twice as high as it would be as if I were born in January. What's going on there? Well, the kids who are the younger kids in the classroom, right? Because in a grade school, you've got kids who are born on January 1st and kids who are born on December 31st, and they're a year apart, but they're all in the same classroom. Those kids who are the youngest in the classroom are actually prescribed ADHD drugs at a much higher rate than those who are born at the beginning of the year. So that really calls into question the whole diagnosis. What are we actually medicating here? We're medicating the unfortunate chance that a son was born in December as opposed to January. And this to me shows the malleability of diagnoses, right? Where the kid, of course he can't sit still. He's a year younger than a lot of his classmates. He just needs to be running around more, doing, he learns at a different rate, but that's not recognized. Becomes a patient, gets a drug.
And let's go back to depression. That's worthy of applause. Because I know I would have been put in a chemical straitjacket if they had them back then. Let's go back to depression for a second. So, because we don't talk about what the natural antidepressants are. So exercise is as good as a drug. Sunlight, 30 minutes of direct sunlight a day is as good as the drug. So there are things that we can do that are as good as the drugs, again, that never get talked about, that don't have harmful side effects. So getting outside and getting 30 minutes of direct sunlight a day, if you can't do that, if you live in the Ohio River Valley or London fog, well, I guess it burns off in the afternoon, doesn't it? A full spectrum light. So getting proper lighting, especially during the winter, hydrating properly, exercising, all these things are major antidepressants that are available without cost.
How are statistics used to mislead people in drug advertisements?
I have whole lectures devoted to that very question. I could answer that with a dozen different conditions. But let me just give you this simple example, which really kind of shocked me one day, and I realized I have to be involved in educating people about this. And this has to do with osteoporosis, okay? So in the mid-90s, in 1995, there was a new drug that was coming onto the market produced by a company called Merck. And this drug, known as Fosamax, you've probably heard of it before, was tested in more than 4,000 women. And these women were diagnosed with osteoporosis. Now, the diagnosis itself, I would argue, is very controversial and probably almost fraudulent. But let's say you've got these women who've been told that they have low bone density. They're 2.5 standard deviations below the mean. So they have lower bone density than other women of their age or of the age that they would have been when they had the highest bone density. So these women have been given a label. They have osteoporosis. They're put in a trial. There's 4,000 of them. 2,000 of them get the drug. 2,000 of them get the placebo. Now, the reason why you are concerned about osteoporosis, the main thing is that if you have weaker bones, you could fall and break a hip. And broken hips, quite frankly, are a public health problem. A lot of elderly people will fall and break a hip, and that will be the beginning of the end. They'll end in a hospital. They may die from that. So preventing hip fractures is a really good thing. So this drug was promoted as preventing 50% of women from having hip fractures. And I saw those numbers and I was blown away. And I said, well, what does the study say? Well, the study of 4,000 women, 2,000 got the placebo, 2,000 got the drug. They followed them for almost 4 years. So let me ask you this. How many of the women who are on placebo, so these are women in their 60s and 70s, for 4 years, how many of those women had a hip fracture? They had no treatment. They had a placebo, which is a inactive sugar pill. How many of them had a hip fracture? What do you think? None. Well, it wasn't quite none. So percentage-wise, was it 10%? These are high-risk women, okay? These are high-risk women. What percentage of them had a hip fracture in 4 years? 5%? Is it 10%? Okay. The answer was 2%. 2% of women had a hip fracture. Oh, but what about the women who are taking Fosamax, the drug? 1% of those women had a hip fracture. 1 in 100. So when you went from 2% down to 1%, that was a 50% reduction. If I had my slides, I will show you the ad where they are marketing this drug as having a 50% reduction in hip fractures when it's only a 1% difference between the two groups. The drug does not help 99% of the women who take it, but is promoted to our doctors and to, frankly, to us as consumers as having a 50% reduction. And if you've ever known someone that's had a hip fracture and that's been the beginning of a very difficult portion of their life, you'll want to do something to prevent that hip fracture. And if someone tells you a drug is going to prevent it by 50%, you're going to say, why wouldn't you take that drug? You'd be an idiot not to take that drug. But really, the drug helps 1% of people. And the side effects, in fact, that drug, the first year it was on the market, had the most reported adverse effects of any drug in the United States. There were more than 6,000 cases of reports of severe esophageal burning and gastrointestinal problems and so on. The drug is very caustic. This was, by the way, the beginning of the osteoporosis industry. And if you read any of my books, all of which have a chapter on osteoporosis, you realize how angry this makes me, because so many of our mothers and our sisters and our aunts and our grandmothers are being deceived by this idea that they have to medicate what they've been told is to be low bone density because of a 50% drug that offers a 50% reduction. By the way, that kind of statistical manipulation, once I saw it with osteoporosis, I started seeing it everywhere. Cholesterol lowering, blood pressure drugs, drugs for diabetes, drugs for depression, and so on. That kind of what we would call using relative risk reductions as opposed to absolute risk reductions. And the absolute is how many people out of 100 would benefit from that drug? And in this case, it was 1 in 100. So the other thing that I find quite fascinating, if you've got this group of 4,000 women, and only 2% of the women on the placebo had a hip fracture, what does that mean? That means that these high-risk women, they had a 98% chance of not having a hip fracture. So do they ever tell you that? Yes, dear Marjorie, we've discovered that you've got osteoporosis. I'm going to put you on this drug. Where the person should say, well, what's my chance of having a hip fracture, say, in the next 3 or 4 years? If the doctor was honest, they say, well, when they studied the drug, 98% of women who are high risk like you did not have a hip fracture.
Dr. Johnson, just to clarify, you're a medical doctor, but were you also an oncologist, someone who treats cancer patients? Was that your specialty?
That is my specialty. I'm not a board-certified oncologist. I came to that through the natural realm, through medicine, doing alternative and complementary medicine. And then as I had success with those patients, they sent their friends, and so that in general became my practice. But what I actually do is life extension, and it's very similar to what you do in normal people. In many ways with cancer patients, you're extending life, and there are many good ways to extend quality life, whether you have cancer or not. At this point, there's a nice tool belt for extending life.
Okay, so how well do chemotherapy and radiation work?
Well, the only way you can really measure that is with stage 4 cancer. That's distant metastases, because we've got good numbers on those. Stage 1, stage 2, stage 3, it's really hard to measure how far that's going. So survival rate in the United States for stage 4 cancer, metastatic, highly metastatic cancer, is 2.1%. So that is way beyond abysmal. That's horrific. Now, if you really want to increase your survival rate, go to Australia. They have a 2.3% survival rate. So what percent increase is that? That's like a 20% increase or something, right? Massive. So those aren't good numbers. So we know that exercise will probably increase your life expectancy by about 10%, 30 minutes a day. We know that going to a plant-based diet will add months, if not years, to you. So we can extend life significantly beyond chemo. The problem with chemo is it destroys the only thing that in the end can save your life. So what does chemo do? It kills rapidly dividing cells. Okay, so what is normally the most rapidly dividing cells in my body? Well, one of those is your immune system. So if you ask an oncologist, will this chemo kill my cancer cells? We go, oh, well, there was a study of 1,000 people, and statistically, these were the best. They might have studied 5 drugs. Statistically, these were the best 2. Oh, will it kill my cancer cells? Well, I don't know. Statistically, they were the best 2. They don't know if those drugs are going to kill your cancer cells at all. But what we do know is that they're going to kill rapidly dividing cells, normally of which is your immune system. So the other thing you've got to understand is it only kills cells that are in a certain stage of division. So chemo agents work at a very specific moment in a cell cycle. And never will all of the cancer cells be in that cycle at any given time. So 1% of the cells might be in that state where they're susceptible to a chemo agent. So you might kill 1% this time, or 5% if you had a great chemo agent, and maybe 5% the next time. You'll never have them all susceptible to that chemo agent. It just doesn't happen that way. So a chemo will never kill, never ever, and you can ask your oncologist, could this chemo ever kill 100% of my cancer cells? The answer will always be no. And so you kind of scratch your head and you go, well, if the chemo was not going to kill 100% of the cancer cells, and assuming I'm going to live and survive this, what's going to kill the last 20 or 30 or 40% of the cancer cells? And I go, well, your immune system. And you go, a little bit of thoughtful reflection. Well, I thought the chemo killed my white blood cells, my immune system. Isn't that why you check a white blood count before you give me the next dose of chemo? I've had patients thrown out of the office at that point because it's kind of like pulling the curtain back from the Wizard of Oz. Because chemo damages the only thing that in the end can save your life. You have to have an intact, functioning immune system at the end of the day if you're going to survive, if you're going to live. Because something's got to finish killing the rest of the cancer cells, because no chemo agent ever kills 100% of the cancer cells unless it kills you too. You can get that kind of massive dose. Radiation, such an interesting study. There were good things happening in areas of treating cancer in the late 1800s and early 1900s. John Baird in England had discovered the use of chymotrypsin and trypsin and digestive enzymes to dissolve cancer, because cancer is other than self. It's not self, it's other than self. And so digestive enzymes, what do digestive enzymes digest? They digest food. Food is not you, it's other than you. So you can use digestive enzymes. And Nicholas Gonzalez, who actually practiced here in New York until he died in 2015, was a major proponent and had thousands of survivors around the world from just using digestive enzymes to treat cancer. So you need your immune system functioning at the end of the day to kill the cancer cells off. And so X-rays came into being in the early 1900s and was held as a new treatment for cancer, the new cure. Never fulfilled on that promise, never has. Now, I'm not against the proper use of anything. I use chemo agents in my practice. I just use them in an intelligent design. Tiny doses, like a 20th of the dose, with insulin. So there's an intelligent way to use things. I'm not against the use of radiation. If I have a mainstem bronchi that's being occluded by a tumor, yes, I'll use that radiation to shrink that tumor, to buy me time to get other things to work. So I'm not against the use of antibiotics. If someone has a life-threatening situation, yes, use them. I'm not against anything for the proper use of everything, for the intelligent design. So X-rays, what do X-rays cause? Cancer. So we're going to treat cancer with something that causes cancer? It's just nonsensical. It's unintelligible.
What financial relationship do pharmaceutical companies have with universities, and what impact does it have?
I think this is, for me, I think this was about the relationship between the pharmaceutical industry and Harvard, the group at Harvard University who were doing a lot of research on pediatric bipolar disorder. And like I was saying earlier, pharma money can help people, a profession and an idea to get respectability. So this group at Harvard University came up with the idea that difficult behavior in children could be labeled as bipolar disorder. It was as ridiculous as that. And yet they were given lots of money to do proper randomized control trials with people that were all given this diagnosis in a very official looking way. And the trials came up with, were all published in mainstream journals and came up with official looking results. And of course, if you give, disturbed children sedative drugs, they calm down a bit, so the results all looked promising. And so it all looked like respectable research until it was revealed that that none of the academics at Harvard who were doing the research had revealed the money that they'd received personally, not just to do the research, but personally from drug companies. And that was revealed by Senator Grassley, managed to get them to reveal that. And they'd received millions of dollars, it turns out, in payments for personal payments for things like consulting and doing talks and things like that. So that finally exposed the influence that the pharmaceutical industry had on this enterprise, on this invention of this condition and research into this condition. But even after all this, I see that there are still papers being published by this group. They're still publishing about pediatric bipolar disorder. They're still recommending that we give children antipsychotic drugs, which, as I was saying, are really toxic drugs with lots of serious side effects, and the side effects are much greater if they're given in children and young people. So sadly, it's still going on. Did you want to add anything?
Well, just, I mean, it's kind of like the reverse Midas touch. The drug money will taint wherever it ends up, and I don't want to say that in a completely bad way. I think the pharmaceutical industry is capable of doing some very good research and have honest researchers, and they can produce drugs that help extend and improve the quality of people's lives. At the same time, in universities and certainly research organizations, I know that we've got the situation, I don't know if it is in the UK, but in Canada and the US, that when you go to the National Institutes of Health or the Canadian Institutes of Health Research, and you want to get a grant, do a study, the first question they say is, who's your partner? Oh, because we like to partner to do research because we want to extend the public dollars that go to research. Well, you look around, who's going to partner for me to study, I don't know, a question around nutrition or a question around exercise or a question around alternatives? Well, there are not very few organizations with deep pockets that can partner with that kind of research. So what happens is a lot of young researchers, when they look at the research world out there, the partners are from the medical device companies, the pharmaceutical companies, the diagnostic testing companies. So they're there to provide money to support these researchers, and hence you get a skewing of the kind of research that gets produced. And I would argue that that's probably one of the problems why the pharmaceutical vision of the world is so dominant, is that the money that goes into the research a lot of it is coming from the pharmaceutical companies. I'm not saying that's a bad thing, it's just that's the way it seems to be working. That's the way business is, and these are large businesses that try to recoup their investment, and investing in university-based research is something that they do routinely. I would argue for more public research, more independent research, people that don't have a vested interest, people who actually want to know the truth, whether something works or not. And to do that, you need an honest study, and you need sort of honest investigators, and you have to report the results, whether they're positive or negative. That's what people want. We simply don't seem to get much of that the way things are set up.
A good example of what you're saying is adult ADHD. So, I mean, it's a controversial diagnosis anyway, but when the UK's government advisory body called NICE, the National Institute of Clinical Excellence, reviewed the evidence on adult ADHD, all there was drug trials. That was all the research that had been conducted. In childhood ADHD, there were studies of cognitive behavioural therapy and other sorts of interventions, so they could make recommendations about other sorts of treatment for children. But for adults, all there was were the drug trials, and so and NICE, I think, sometimes makes some really good decisions, but in this case, I think it wasn't so good, because instead of saying, look, there are lots of other things that we should be looking at, they just said, prescribe the drugs. That's the evidence we've got, so drug treatment is what we recommend.
When we go to a doctor, again, the doctor's a very busy person, and they have to get information from somewhere. So one source of how they learn to keep up with the information is medical journals. Should we assume the medical journals offer accurate, unbiased, scientifically based information, or should we assume they are financially influenced by the pharmaceutical companies?
We may have covered this already, so stop me if I'm repeating myself, but one of the things that medical journal, one of the things that researchers want is they want their research done in high impact factor medical journals. So the medical journals are ranked. Impact factor means a lot. It means other medical journal, other studies will cite them, and they can charge more for their advertising if they have a high impact of their journal. And so what happens is that the companies will try to get their stuff published in the highest impact journals, and then they will do what is called reprints. And a reprint is a photocopy or a copy of the study that was in the journal. And a lot of times, it makes the journal a heck of a lot of money. In fact, I think for Vioxx, the reprints, if I remember rightly, was somewhere in the neighborhood of the journal that published it made $900,000 from the company, just allowing the study to be photocopied. And that study becomes a marketing tool for the companies who go around and visit your the sales reps who go around and visit your doctor and say, oh, by the way, there's this new study in the New England Journal of Medicine, and here's what it says. Look, it's New England Journal, high impact, there's the study. And that has an influence because it's a reputable journal, and it's got all the impressive credentials of the universities that would have been involved in it, and the people that had carried out the study. So yeah, journals make an awful lot of money. Some have argued that they are basically money laundering for the pharmaceutical companies. I don't know if I'd go that far, but over the years, what has been really important in medical journals is that they are reporting the conflicts of interest. So when you read a study, it'll have lots about the methods and how they did it and what the results were. And the fine print right at the back will tell you what I think is almost most important bit of detail. It'll say who funded the trial and what were the financial conflicts of all of the researchers. Dr. Joe Blow he's on the speaking tour for the company. He's on the Speakers Bureau for the company. He owns shares in the company. He owns the shares in the patent of the product that's being tested, etc. That will all be listed. And I would argue, but also research has been done on this. I do try to back what I say with research. Research has been done on this so that those conflicts of interest, the fact that the people who are doing the research are financially benefiting from being part of that study, that information will tend to make the results look much more rosy than they otherwise would. We'll just put it that way. So medical journals are really important, and it's good if you're ever going to read a study in a medical journal to flip to the back and find out what the financial conflicts of interest of the investigators and of the trialists are.
And also of the editors. There have been various scandals about editors who've been revealed to have conflicts of interest and be taking a lot of money from pharma.
What is the DSM, and is it a good and accurate manual?
That's you.
The Diagnostic and Statistical Manual is what the American Psychiatric Association produce in order to give a label to various forms of mental distress and disturbance. And the WHO also produced a similar manual called the International Classification of Diseases, which has a section on mental disorders. And from my point of view, the main problem with this is the confusion that it's called a diagnostic manual, because it gives the impression that when you give someone a diagnosis from this manual, like clinical depression or bipolar disorder, you have pinpointed the underlying cause of their problems, as you would if you gave someone a diagnosis of lung cancer or tuberculosis. But it's not that at all. It is a series of descriptions which then just lead to labels being put on behaviours, and it's completely tautological. If you show this, this behaviour and this behaviour, if you're unhappy for 2 or 3 weeks and you feel worse in the morning and you've gone off your food, you will get a diagnosis of depression. What depression means then is that you have those features, that you've been unhappy for 2 or 3 weeks, that you've gone off your food, and that you can't get to sleep at night, or whatever I said. So the label is actually not giving any additional diagnosis. It's just a name that's being stuck on your problems. But the implication is that it's something more than that. And of course, it's the DSM has had all sorts of implications. It is a gateway to medical care, gateway to welfare benefits, leads to, links up with various drug treatments, and drug companies will take disorders from their DSM and think, oh, here's one we haven't targeted before. We've got this old drug hanging around in the corner. Maybe we could link it up with this diagnosis and give it a new lease of life. So that's how it works sometimes.
It's a very controversial document, the DSM, and controversial because diseases that appear in the DSM or conditions have changed over the years. In fact, there are some things that were in earlier versions of the DSM are not there now. For example, homosexuality used to be considered a
disease.
A disease. And the latest version, which I looked at, they described what used to be just known as grief. This is so when a loved one dies, a mother or father or child dies, people go through a certain period of grief. It's very normal. It's very natural. People deal with it in many religious or non-religious ways, but it appeared in the DSM as a form of depression, or a form of basically that you can't cope with your grief. And the only reason that I could see that appeared in the DSM was this just became another market for the antidepressants. It's because in the past, maybe after 2 or 3 months, if you're still having serious grief, then you might see your doctor and have some treatment. But I think they shortened it to something like 2 or 3 weeks. If you go through 2 or 3 weeks and you're still grieving after that, suddenly you have a serotonin deficiency and you have to take an antidepressant. How absurd is that? And part of the problem, and I think you alluded to this, is so much of what is in the DSM is subjective, and it's not the problem with the DSM itself; it's how it gets used in the real world. And in the real world, it gets used to encourage a lot of, I would say, excess pharmaceutical use.
And I think what it does very often is it puts a stamp of approval on the use of drugs which might otherwise be called into question, like prescription of antidepressants for people who are grieving. Somehow it makes it respectable and scientific sounding, when actually it's just putting a label on someone and dressing up a situation that is really wrong.
I think back on the farm we call it hogwash.
Dr. Ben, what is your approach or advice to someone who has advanced cancer?
It's a good question. Don't believe the words of the prophet in the white coat that you're going to die on schedule, on time. Exercise. Think positive. Change your diet. So here's the diet. First is vegetables. Second is vegetables. And third is vegetables. Fourth would be nuts. And fifth would be low glycemic index fruits. So change your diet. Change your gut biome. Get you a nice mix of healthy bacteria in there. Lots of sunlight. Be around positive people. I studied centenarians around the world, and up in the Kashmir region, down in Vilcabamba, Ecuador. We actually have one in the U.S., Loma Linda, Japan. And they had 5 things in common that I could find. I call them the 5. I was able to come up with an F for each one of them. Fluid, they were all drinking healthy, clean water without chlorine or fluoride in it, without chemicals, without pharmaceuticals. They were eating fresh food out of the garden without chemicals or pesticides or artificial fertilizers. 3, they all had faith. They all were in relationship with their God. 4, they were all in relationship with their family. They had family. Now, we move a lot these days, so if you don't have family close by, create family. Friendship is really important. And then function. I remember little Maria. She was about 4'6", down in Vilcabamba, Ecuador. At 105, she was still the midwife. Okay? She still had a function. So if you don't have a job, get one. If you can't get a job, go volunteer. If we don't have a use, then pretty soon the universe has a way of getting rid of, if we aren't useful, then we disappear. So be useful. So all of those things are important. But water, exercise, thought-filled is huge. Thinking positive, being intent, visualizing, connecting with a physician that has different possibilities. Get on board with that. So there are a lot of ways to extend life. There are actually some life-extending drugs. There was one that was in the UK for decades, metformin, that the pharmaceutical companies in the US were kept out literally for decades. It's used for diabetics primarily. It's truly a life-extending drug. It normalizes blood sugars, but if you take 1,000 people that don't have diabetes and 1,000 that do, the diabetics are supposed to have more heart attacks, more strokes, more kidney disease. You put them on the metformin, and they have less than their peers who don't have diabetes. So there are different life-extending drugs. Metformin would be one of those. Rapamycin would be another. There's life-extending herbals. Curcumin is absolutely a life-extending herb. Astragalus, there are some amazing herbals out there, plant-based homeopathics that are very good, natural antifungals, and including drug antifungals. So there's a lot of ways to push back against cancer and to extend quality of life, if not continue to live to the ripe old age.
If anyone in the audience would like to ask a question, raise your hand. I'm going to ask another question, and then after we'll give you a microphone. How did Eli Lilly make Zyprexa into such a successful drug? What was their marketing strategy to achieve this?
So I think I touched on this earlier. They decided that they were going to, when the atypical antipsychotics came out, the first objective was to replace the older drugs in the treatment of people with psychosis and schizophrenia. When that had been achieved, they decided that they were going to try and get into the much, much larger market of people going to their doctor for depression, and they managed to achieve that by getting licensed for the treatment of bipolar disorder and treatment-resistant depression. So I don't think I'll say any more because I think people want to ask questions.
My question is with regards to drug patency. It seems like in more recent times, when the drug is expired, they seem to come up with a modified form of the old drugs so as to maintain its patency again. Can you comment on that, Alan?
Maintain its patent.
Yes. So the question is, drugs off patent become back to the market in modified forms and repatented. When a drug is off patent, then it allows other companies to make it, so you can buy generic drugs, and they're cheaper. They're therapeutically equivalent to brand drugs. There are some really good examples of companies that have taken drugs that have come off patent and then repackaging them and back onto the market. Now, my favorite example is a drug called Serafem. Have you ever heard of this? So Serafem is a drug for PMDD. Have you heard of that? PMDD stands for premenstrual dysphoric disorder. Yeah, okay, so this is, now I'm not arguing that women don't have difficult periods. That happens. This drug is basically Prozac that has been repackaged. So when Prozac, which was made by Lilly, came to the end of its patent protection and was going to be made generically available, they took the generic fluoxetine and they did some fascinating things. They changed the color of the capsule to, Prozac I think is yellow and orange, I think. But Serafem is pink and lavender. We call it Prozac in pink. It's basically, they've taken the drug, put it in a different colored capsule, and sold it for a new disease that I think they had, had a hand in creating. Talk about a license to make money. So this, by the way, happens in other conditions where they've taken drugs off patent. I mean, there's the example of, EpiPen. You know what an EpiPen is? It's an epinephrine. It's an emergency medicine for people who are at risk of having an anaphylactic shock. Well, I almost had an anaphylactic shock when I heard that they raised the price of EpiPens by 400% in the last few years. And I thought, how can they get away with that? Well, the basic chemical in epinephrine has been on the market for 37 years. It lost its patent decades ago. So how could they now sell this EpiPen for 400% more than they used to sell for? It was already very expensive. Well, it's the injected device. So it's got a spring-loaded thing and you smack it against your leg and it goes in and it's an auto-injector. So the auto-injector had a couple of patents on it, and those patents have been extended to 2024. So the company, since can charge whatever they want, and thankfully in the U.S., I believe there are alternatives to EpiPen. You can buy equivalent auto-injectors, but this is an example of, it's not about health; it's about money. If we can get 400% more out of our patent on the auto-injector, why wouldn't we do that? That's what we're providing value to shareholders.
And then there's the orphan drug situation. In the last few years, we've seen tetracycline, which costs 2 or 3 pennies a capsule to make, go to $4 or $5 a capsule. We saw the same thing with colchicine, pennies to make. I think it's $4 a pill. So it goes off patent, and then only one supplier is making it, and they'll buy that, and then they'll take it off the market. Now it's an orphan drug, and they go back in and they say, oh, we're going to patent this for this period of time because it's orphan drug, and they put it back on the market for an exponential price. All kinds of ways to make money. We're in the wrong business here.
About the mammograms, if we don't get mammograms, how do we detect cancer? If we feel a lump, maybe, I don't know what we should do. And the other question is there any truth to, is it true that women who don't have children have a higher estrogen level and thus may be more apt to get breast cancer?
So let me answer the second question first. We know that women who breastfeed before the age of 21 have less cancer. So the functional use of that gland before the age of 21 does decrease breast cancer incidence. The flip side you never hear anything about is abortions dramatically increase the rate of breast cancer. That's because those glands are rapidly developing, and they're suspended in that state of rapid development, kind of like a cliffhanger, and you don't hear any press on that at all. Estrogens, progesterone, the Premarin, the drugs like that stimulate the glands, and so anytime you're stimulating those glands with estrogen, you're going to increase the rate of breast cancer. So that's why, and why breastfeeding below the age of 21 decreases, don't have a clue. After the age of 21, it doesn't seem to matter so much. Back to detection. So there are other devices up there. There's thermograms, which is a infrared picture of your breast, or actually you can take an infrared picture of any part of the body, It's very interesting. Thermography, and I'll cover that in my lecture on Saturday significantly. You can see pain with an infrared camera. I'm not aware of any other medical test where you can see pain or detect pain. You can see a neurological deficit. You can see inflammation. You can do a generic blood test for inflammation or inflammatory markers, but you can see inflammation on a thermogram. So it's the most underutilized test available. So when there's a cancer in the breast or something growing there, it has to have increased blood flow to grow. Well, that's called heat. If you've got more blood flow to something, there's more heat. Also, all of the cancer cells aren't surviving. Some of those are dying off. And as they do, cancer cells are particularly toxic. So those toxins dilate the vessels all the way up to the skin, allowing the release of nitrous oxide to the skin, and that shows up as heat too because it's dilating the vessels to the skin. So a lot of times you can see progression of tumor or cancer effect in the breast by following an infrared camera with infrared camera, and that's called a thermogram. They're about, all according to which camera is being used and who's studying it and what program is being used to interpret, between 60 and 90% sensitive. Another great test is ultrasound. It's about 90% sensitive. Now again, let's compare that to what's being foisted upon women. Mammograms, women under 50, it's only 52% sensitive. It's going to miss 48% of the cancers. That's horrifying. Whereas ultrasound would pick up about 90% of them. So why aren't we doing more ultrasounds and thermograms? Because between those two, your sensitivity gets up above 95%. If you do a thermogram and an ultrasound, you're way up there, as opposed to around 50% with a mammogram for women under 50. Well, the hospitals have invested in these $500,000 mammogram machines, and it's breast disease and breast cancer is an industry, which, like psychotic and ADD, we've created an industry. We've created a disease, and we're propagating that disease. So if you get enough mammograms, they have a built-in patient. You're going to get breast cancer, or a certain percentage of the women will get breast cancer, and there's a built-in, what a nice money funnel. Built-in patients by the process that you're doing to supposedly detect cancer. And then there's MRIs. MRIs are quite sensitive. There's not enough MRI machines to go around that, to do all of that, and not enough doctors trained in it. It'll take another 10 years to get enough doctors adequately trained to read all of those MRIs. It's a more expensive procedure, so the insurance companies don't want to pay for it. But you'll always get the crush by the doc if you ask for an ultrasound. After your mammogram, or if your mammogram shows something. So there's that funnel to pressure women into mammograms, and if you read the research, it causes breast cancer, and we know clearly now that women that get mammograms die 4% more often than women that don't. So not a good test to be doing. So I would recommend thermography coupled with ultrasound. Thermography is a test of physiology as opposed to MRIs, mammograms, and ultrasounds are tests of anatomy. So they're totally different tests. Most doctors aren't used to looking at thermograms, so they're not used to looking at physiology, so they don't quite know what to do with it. So those are the recommendations. And of course, breast self-exam. Most lumps are found by their owners. So do that. The best way is in the shower. And I've never asked a woman, I've examined 10,000 women, so it's about 20,000 breasts more or less. And I would frequently ask, do you examine yourself? Yes. Oh, show me how you do it. And it's like, And so there are good models, there are good videos. We have the internet now. Go in there, learn how to examine your breast. There are models that you can buy and purchase and learn how to examine. So there's good information out there. Get it, apply it, and examine your own breast, because you're the owner, and no one should be more concerned about your breast health than you.
In Europe, the Mirena IUD is very popular, more so than in the United States. And it releases hormone very strong in the beginning, and it's for 5 years, a birth control method. And my question is, if you know any research where it's detrimental as a carcinogen, and also my question that it's not very natural if it stops a woman's menstruation cycles for such a long time, and what you believe about this, and what birth control methods you.
We clearly know that estrogens cause breast cancer, and that's a progestin type. That's a progesterone dominant application. There's not near as much evidence to date. We don't know what the drug company may have not divulged, so the data may be out on that. And I would just have to say, if it ain't natural, it's probably not healthy for us. But I don't think that if you're asking for scientific data, that's not in yet. There are great ways for birth control. Rhythm, if you're watching your cycle and taking your temperature, checking your mucus, you can tell exactly when you're ovulating. You don't have sperm available there when you're ovulating, and it's, as long as you're regular, it's pretty successful.
Can I just give one bit of advice, and that is in the U.S. they have a group called the National Women's Health Network, unfunded by the pharmaceutical industry. They're separate. In fact, they're probably one of the best examples of consumer activism when it comes to pharmaceuticals. They were at the forefront of forcing the FDA to provide patient information around the birth control pill when it came onto the market in the 60s. They have a website, they have very good conferences, and they produce very good quality publications.
You have to understand a lot of these things are not tested well because, for instance, breast implants, they're not tested. They're not studied. They're grandfathered. They may come up with a whole new substance for the sac and and they'll be grandfathered. So IUDs are in a similar situation. They'll come out with a new drug and a new way of it working, and they're grandfathered. So a lot of these things aren't well studied at all. You assume you're being protected by the FDA. A lot of times you're not.
I had a question. Do you hear me? Oh, yeah. I had a question with your mammogram. If a woman comes in to see you and they want to do the standard mammogram test on her, but she chooses to do the ultrasound, would the insurance company still help, cover with that type of an exam as a mammogram exam, or?
The insurance should pay for an ultrasound. It won't pay for a thermogram, but it should pay for the ultrasound.
As a mammogram exam for her?
As a what?
As if she's getting diagnosed for, as she's getting an examination for her mammogram, it's okay to use an ultrasound.
The doctors will try to pressure the woman into a mammogram. There is no state law saying you have to have a mammogram before an ultrasound. There's no insurance rule saying that you have to have a mammogram before an ultrasound. It's just the way they do it. It's called standard of care. And nobody's proven that that's better. It's just what they do, and they're going to try to pressure you into that. So, but a beautiful thing is you don't need a doctor's prescription to get an ultrasound. You do not need a doctor's prescription. You go into Walgreens or CVS or some of these, you'll see them doing ultrasound screenings. They're in a pharmacy. Did the doctor write that prescription? We need prescriptions. You have to have a prescription for something that causes harm. X-rays, drugs, chemicals, surgery, okay? and ultrasounds haven't been shown to, and so they're kind of one of those things that kind of got grandfathered. An ultrasonographer does not have to have a license by a state, or actually I'm not aware of any state that licenses ultrasonographers. Now, you may not be able to find one that does them, but they literally do not require a prescription. It might require a doctor's license to interpret it, but I'm not quite sure about that. But ultrasounds are obtainable without a doctor's prescription if you can find someone doing them.
Thank you so much. We've learned so much throughout the night. I have a question for, I do counseling with children and adults with different mental illnesses, and I have a hard time not only with the medical field, but with the education system, because they are very, like you said earlier, they're very geared towards conforming all children to be alike. So if I have a child or even an adult, what is your preference on how to go about and help with their anxiety or depression in a more holistic, natural way? I mean, I use oils, I use cognitive behavioral therapy, we do play therapy, but what are there some other options that you would recommend to help those with depression, anxiety?
To me, it's, I work mainly with adults. And to me, it's an individual thing, and each individual is in a different situation and has got to you through a different route, and it's working out how and why they have ended up in front of you and what you can do about the situation that has brought them there. With children, it's often about working with the family. I know that's not always easy or not even always possible, but that used to be the absolute standard of care for children in the UK, but much less so now. We've sort of medicalised it all. But I think that is the best way, because it is going to be a problem in the family, or maybe in the school system, in which case you've got to involve people from there. So I think it's just very individual, trying to work out what that individual's problems are that's brought them to you.
If I can speak to that, one of the cofactors in the skyrocketing diagnosis in the US was they stopped having recess. So these little boys who couldn't sit in their seats in the first place couldn't get outside and burn off some of that energy. And then, so exercise is critical, diet, plant-based diet, get off of all the sugar, and let's define sugar. Sugar is anything white unless it's cauliflower, and grains are sugar, and that includes quinoa, oats, wheat, rye, corn, whatever it is, starches. So those are gas on the fire. So you've got to have a plant-based diet, off of the sugars, lots of exercise, sunlight. So those are the things that you want to be doing for these kids.
Thank you. I have a few questions going through this talk. One, I'd like to hear Alan's answer to the thermography question. Two, I'd like to know more. It was mentioned standards of practice and the implications of that. Three, what's an anti-sickness drug? And four,
I guess just pick one. Pick one question. One question.
well, I think
Just pick one so other people can go. Just pick one.
So quickly, I don't have an opinion about thermography because I don't know the research. That's my answer. I'm going to have to sit through your talk to find out what he has to say. So sorry, I don't have an answer on that. What was your question about standards of care?
I thought it was standards of practice.
So can you be a bit more specific?
well-
What do you mean?
Well, yeah, because my very vague understanding of it is that there are certain standards, say, that are being written into, for instance, maybe the insurance rules or the way doctors approach treating a patient.
Okay, if you're just speaking broadly, standards of care, I mean, this is a question I have when I talk to lawyers about, when I ask questions like, is this example of prescribing something that could be considered to be, unlawful or illegal or unethical, and the question they always come back to me, well, it depends on the standard of care. But what defines the standard of care is how everybody else is practicing. So if you have a kid that comes into your office that that the parents and the teachers are saying is too rambunctious in class, and you prescribe the kid an attention deficit disorder drug, an ADHD drug, that's probably meeting a standard of care, because that's what any other regular doctor would do in that situation, which defines the standard of care. I think that it should be defined against a evidence level of care. Like, what is the evidence of benefit and the evidence of harm and the options, the other options other than a drug that the person could take? I think that's what it should be compared about. But it isn't. It's compared against what what a reasonable physician would do in that situation. And I have lots of criticisms about the standards of care, because I think the standards are often way out to lunch. So I'll just leave it at that. And you had something about, what was your last one? Anti-sickness drug. You mean like a Gravol? That's what we call it in Canada.
A drug that's prescribed for sickness or nausea. They're sometimes called antiemetics. An example from the UK would be Stemetil, but I don't know whether that's prescribed here. I don't know any others because I never take them.
Yeah, I'm in my 60s, and so I have prostate cancer cells in my prostate right now. Are they going to kill me? Not likely. But if I were to let a urologist biopsy me, he'd probably find some prostate cancer cells there and want to treat me for prostate cancer. So just because you have a cancer cell doesn't mean that you're going to get cancer or die of it. And so what all these screenings do, whether it's PSA or mammograms, is they lead to overdiagnosis and over-treatment and intervention, which causes problems. So it's, again, if there's a woman over 60 or a man over 60, you're going to have those cancer cells in the breast or the prostate. They're okay there, and as long as we don't disturb them. You go sticking a needle through there and knocking them out of where they are used to being, where the immune system has them contained, and all of a sudden you've got the fire outside of the fire pit. So we want a fire. We want it in the fireplace. We don't want it in the house where it's going to burn the curtains down and burn the house down. So we're going to have fires. I have prostate cancer right now. Is it going to kill me? No. So we all have cancer cells. Is it going to kill us? Not unless we're treated for it.
Okay, so I would like if each of you would take up to 3 minutes to just make any closing thoughts on anything that you want to communicate to us about tonight, or just general information in this area that you feel is important that you want to conclude with.
Did you want to take one more question first?
I'd say we're out of time,
We
so
have
why don't we just do closing statements, right? So we have enough time.
So I'll be very brief. I think in arguments with my colleagues, we often talk, how do we improve the system? How do we improve prescribing so that people who actually need the drugs that are actually helpful are getting them, and people who are not sick or are just worried well, and they are not overly medicalized? What do? Do we spend time educating physicians, or do we spend time trying to educate consumers? And we have this back and forth discussion all the time. And I can tell you the reason I write books and I write magazine articles and so on is that I think that at the end of the day, the consumer is the person that needs to be educated. The consumer is the one that's going to go to their doctor and challenge their doctor and ask hard questions. I'm not saying be a nihilist or be a cynic. I say being an involved patient. Ask hard questions and question the answers. And I would ask everyone to take a little bit of courage, because I know it's not easy when you're facing off someone with a prescription pad and they want to give you something. And so I would say that most of the time, whatever you have is probably not an emergency, and you can take your time to get a second opinion, to get a second look, to do some more research, to find good quality, unbiased information on the internet or so on. And so I would just argue that people would not automatically assume that what you're told by someone who's thrusting a prescription at you, that's the only way to treat what you've got. There might be many things, including doing nothing.
Absolutely. I'll clap for that.
I'd completely support that. I think the medical profession, led by psychiatrists and encouraged by the pharmaceutical industry, has completely lost its way when we think about mental health problems. We've lost all common sense, and I think that has to be brought back by you, by patients, by members of the public, questioning and rejecting attempts to pigeonhole people, to stick simplistic labels onto problems, and to pretend that there's a nice simple solution in the form of a pill. So we've got to resist that, but doctors are not able to do it at the moment, so it needs to come from the public.
Hippocrates said, and most of us have heard the quote, "Let your medicine be your food and your food be your medicine." There was more of the quote before that, and I don't recall it verbatim, but it's basically he said that all of us have a physician within ourselves. We just have to empower and enable it to heal to release healing. And then the famous quote, "Let your medicine be your food and your food be your medicine." So start with the basics. Healthy water, healthy food, exercise, sunlight, relationship, faith, function. Start with those basics. If you get the diagnosis of the big C, if that ever happens to you, then press the pause button. We've all got a pause button. Press that. Seldom, I was counseling with the patient yesterday doing a consultation. I said, the first thing you need to do is take 30 days, research your condition. I want you to know more than I know about it. I want you to know more about your diagnosis than your doctor does. Then go to the surgeon, find out their recommendation. Go to the oncologist, find out their recommendations. Go to research alternative. Counsel with someone who's open to all of these possibilities. Seek divine wisdom, and then make your decision. Don't get the bum's rush. Don't get the bum's rush down the hole. Oh, we've made you an appointment next week for the oncologist. Oh, we've made you an appointment next week for the surgeon. So, pause just a moment. You have to set the stage. You go in and you get that diagnosis. You go to see the surgeon or the oncologist. You say, "I need you to understand something. I'm the owner of this team. This is my team. I'm the owner. I'm the general manager. You are a potential player. You're in the dugout. Now, tell me what you know and why I should let you play on my team. Why should I let you on my playing field?" So you have to set this up because doctors are used to being in control, being in charge, telling you what to do, and their perspective on what should happen here. But you need to set the stage. No, this is my team. This is my body. I get to decide what's done here. So set that stage. Set the playing field. My body, my team. Tell me what your counsel is. I will consider it. And I'll call you if I want you to play.
Dr. Ben, if aside from going to Amazon to buy your books, if someone wants to connect to you, are they able to call you? Do you do consultations? How would they stay in touch with you or connect to you?
I do. Best way is info@drbenmd.com, drbenmd.com, info@drbenmd.com, and my help will get us in touch.
And Joanna, aside from your book, The Bitterest Pills, that they can get on Amazon, is there, if someone wants to connect to you, how would they do that?
So I've published 2 other books, including a sort of small, short guide, which might be more easily digestible for some people. And I've got a website, and I blog on there, and people can contact me via that. But I don't. But I should say I don't. I don't see private patients or patients outside my sort of clinical geographical area.
And if you go to realtruthtalks.com and click on their picture, it'll take you to them. Alan, if people want, aside from buying your books on Amazon, is there any way to connect to you if they would like to?
They could buy them here. They're right over there.
Definitely.
I'd sign them and give you my email address. No, my website's on your website, so my contact information is there. You could Google me and find me.